Atrial fibrillation, also known as AFib, is the most common heart arrhythmia. It's characterized by misfiring in the atria. Typically, the SA node fires and it moves to the left atria as well as being held at the AV node and going down to the ventricles. However, in AFib, there is extra stimulants and contractions in the atria, which you can see over here. It's not just coming from the SA node, but it's also coming in seemingly random directions in both the right atria, the left atria, and other places as well. Atrial fibrillation is characterized by tachycardia, an irregular, fast heartbeat, normally between 300 and 600 beats per minute, averages about 60 to 100 beats per minute, so that's clearly a lot faster than average. If we look over here at the normal rhythm strip, we see a rhythm about 80 beats per minute, and you can see normal P wave and QRS complex. But if you look below it at the atrial fibrillation rhythm strip, you see everything is very fast and out of whack. You see that the Q wave is extremely high in this position right here, and it's also lower here, and it's seemingly absent in the middle. The P waves are superimposed in the T waves, and it's very fast and it's very out of control. It's typically characterized by asynchrony, where normally the atria and the ventricles are in sync. However, in AFib, we don't have that. The atria are contracting, the ventricles are contracting, but they're seemingly independent of each other. They're not following that rhythmicity and that cohesiveness that normally occurs between atria contracting followed by the ventricles contracting. Some of the symptoms we see in AFib are heart palpitations, shortness of breath, and weakness, and it's also associated with a variety of heart conditions such as congestive heart failure, dementia, syncope, which is dizziness or fainting, stroke, and blood clots. And it's also associated with other bodily systems such as the endocrine system, the pulmonary system, as well as other exogenous forms such as caffeine and alcohol, which can affect your heart rate and blood pressure, as well as endurance athletes and high altitudes. Again, when we look at AFib, you can see that it's not just the SA node firing, it's all of these extra beats, possibly premature beats, that are coming from the atria, which are causing this very irregular conduction pathway to go not only down the Purkinje fibers to contract the ventricles, but it's also conducting in retrograde back from the ventricles to the atria. And again, it's with this rapid beat which is not regular. Looking a little bit at the epidemiology, we estimate that there's about 2.7 million Americans with AFib, and we can see just how common AFib is compared to all of the cardiac events, because it does make up about 50% of all the diseases that lead to cardiac events. Looking at the Framingham study, we looked at about 1,000 men and 1,000 women, and we found that the occurrence in AFib in men is actually fairly significantly higher than women. And here, 21.5 out of 1,000 for men and 17.1 out of 1,000 for women, which doesn't seem like that big of a change. When looking at a much higher population, we can see time and again that the men will be much more likely to have AFib than the women. We have found that the predominant risk factor of AFib is going to be age. Typically, we're focused on age 50, which is where we see the most cases of AFib. And with that, every 10 years after age 50, the risk for AFib will double. And in addition to that, we also take a look at the geographic locations for AFib, and we do find that our Western countries have a much higher occurrence of having AFib, which is affected by age. In fact, we do look at China, for example, and we found that they have a 50% lower incidence of AFib when we look at men at the age of 50 compared to other men living in the equivalent Western culture of people of the same status. We find that the Chinese population has a much lower risk of having AFib, as well as looking at African Americans compared to Caucasians of the same age in the same group. We see that they have a 25% less risk of having AFib. And we do also see that this is growing globally. Looking at the pathophysiology, one of the biggest things that promote AFib is the increase in the atrial pressure, which is going to cause all kinds of spontaneous contractions and conductions of the SA node, things in the atria, as well as misfiring in the mechanistic pathway. We do take a look at Gordon Mohs' work in 1962, who wrote this paper on multiple wavelet hypothesis, where he's basically trying to identify what it is that's perpetuating the atrial fibrillation. And you can see down here that these waves of conduction pathway are seemingly random, coming from both the atria and the ventricles. And what he is basically explaining is that he thinks that perhaps it's coming from a depletion in potassium, and also perhaps there's a depletion in acetylcholine, and there possibly might be a vasostimulation, which is causing that decrease in heart rate, that decrease in blood pressure. He also talks about different ion deficiencies, and he talks about this circus movement, which is, again, looks just like these waves, just kind of circling around, branching off of each other, just going in seemingly random directions because of possible ion depletions. He also talks about the atrial refractory periods, in that he believes that the atria are in a decreased state of refractoriness. They're not allowing that pause in depolarization, which is not giving the heart enough time to contract and depolarize. So the impulses are firing at a rate that's faster than the heart can actually contract and depolarize. And again, that's causing this fast heartbeat and irregular beat. And it's also characterized by a bigger heart mass, because the larger the mass is, the more area that these waves can fit and cause those conduction abnormalities. Again, we talk about the sodium channels, which may be contributing to this misfiring. Perhaps there's extra contractions that are going on. There may also be some inflammation going on in the AV valves themselves, in the pulmonary valves themselves, oxygenated blood coming in and coming out. Interestingly, in 1998, the Bordeaux group published this anatomical source, which was really trying to understand the focal initiation of where the impulses were coming from, and they actually found this stretch response that would occur in the pulmonary veins that were oxygenated, in which when the veins were stretched out, which would occur from regurgitation of blood coming up from the AV valves back into the atria, it would actually cause an increase in pressure, and it would cause this stimulation of the heart to pick up its pace, and again cause this out of whack synchronous. So looking at treatment and medication, primarily your treatment for AFib is going to be drugs that are going to essentially thin the blood. So we're looking at warfarin and aspirin are our main therapies. We find that warfarin is actually much more effective than aspirin. I believe there's a 70% higher likelihood of a decrease in possible adverse events for AFib with warfarin as opposed to aspirin. Another very popular procedure done is cardioversion, where the surgeon will surgically implant electrodes into the heart and shock it to go from that atrial fibrillation into a normal sinus rhythm. They try to stay away from dietary substances because it can have a variable effect on metabolism, so it's not normally prescribed. But the biggest concern in AFib is the rate control, in where we want to make sure that the heart rate doesn't get too high, which again can cause all kinds of mortality rates and issues. But what's interesting is that even after people were able to get such electrical shocks when the heart rate was too high, they found that the patients actually didn't have an increase in survival rate or any kind of benefit once they went from AFib into the normal sinus rhythm. So it's still kind of a tricky topic, but it is normally done to shock the heart to get it back into that normal sinus rhythm. Again, so there are other drugs that can be used, such as beta blockers and calcium channel blockers. Again, they're going to slow down that heart rate. They're going to lessen that strain, that pressure we talked about before on the atria. The cardiac muscles are going to be able to resynchronize. And there's also various other drugs that can block the vasoconstrictors and vasostimulants that are going to lower your blood pressure, that are going to lower your heart rate. Now, a lot of doctors really do recommend the electrical training, but again, it really does depend on each patient and whether there's any kind of ablation or a pacemaker or what that patient was eating that day. So a lot of it is you need to talk to your doctor first before taking anything over the counter. Looking at exercise, there was a study done to test the exercise capacity of 532 people, and basically there wasn't very much data to talk about the benefits and response of exercise on AFib patients, but they did find that patients who had the worst conditions, who had diabetes and hypertension and had low exercise capacity and were on all kinds of medications, that there was a much higher increase in exercise capacity after 6 months of training than without. So it is found that exercise increases the exercise capacity for AFib members, but it's not extensively proven. The most research out there tells us that the safest way to exercise with AFib is low to moderate intensity, staying away from any kind of vigorous activities. And so some things we want to be careful for are any kind of excessive heart rate, heart palpitations, dizziness, sweating, anxiety, things of shortness of breath, anything that might make it more difficult for the patient. Looking at a case study, looking at a man who's 67 years old, who was rushed to the emergency department for having palpitations and trouble breathing. He does have hypertension, diabetes, and GI reflux, and he's on metformin, lisinopril, and omeprazole. Doesn't have any history of heart problems. We look at his blood pressure, which is 88/60, his pulse rate 140, his rest rate 24, and he did have an irregular rhythm. So what we would do is we would stratify him as a high risk and have him supervised by a physician, and we would make sure that he'd undergo immediate blood thinning treatment to make sure that he's back at the normal sinus rhythm, as well as putting him on metroprenol to make sure that he gets back to that ventricular rate. And the prescription we would give to him would be low to moderate cardio exercise, which would increase as necessary, starting at 3 times a week at intensity of 50 to 70% his max heart rate, RPE 11 to 15, starting with bouts of 10 minutes of exercise 3 times daily, and progressing into 30-minute intervals as tolerated. And we would do cycling and walking, and we would make sure that he periodically checks his heart rate, and it will increase from there. And any symptoms of disorientation or heart rate or anything we talked about before, we would stop immediately.